His session today is Personalized Population Health, the Future of Wellness Care. He's going to explore how large-scale data analytics and predictive modeling can revolutionize public health, helping nations like Mauritius design smarter, more preventive health systems. So please join me in welcoming Dr. James Yurkovich.
Hello, everybody. Thank you, Brian. Thank you very much, Nadine and Damien, for inviting me here and letting me be a visitor on your beautiful island, and also for the opportunity to come and talk about a bunch of stuff that I'm really passionate about. So I'm going to talk right now about kind of a vision for how some of the new and developing technologies that are available right now and coming in the next few years, some of which we're working on ourselves, might be implemented to positively impact wellness care, healthcare, sick care in the future. And then later this afternoon, I'll dig into kind of some specifics about one clinical trial in particular that we are running, and how some of these technologies, particularly AI, is useful in some of those areas. So I want to start off by providing a little bit of motivation. This is kind of old hat if you've been here the last couple days listening to some of this. 4.3 trillion US dollars. That's a really big number. That's the total healthcare spending in the US. And that's projected to increase at a rate of 5.4% per year. And what's really astonishing, if that number isn't already astonishing, is that 97% of those healthcare dollars spent are spent after the diagnosis of disease. That means after these chronic diseases have already developed and are progressing, that's when we really take action. And what I'm here to talk about today is a vision for how we might start to shift that so that we're not only spending money after the diagnosis of disease, but before, to perhaps prevent disease altogether. Now, a lot of different groups and organizations like Deloitte have thought about what is the economic benefit and burden of these kinds of shifts as we look at it. So this graph behind me, this is historical data on the left, the white, and then these red bars are the projected costs. Of course, this is already a huge number in healthcare spend, and it's becoming even more unreasonable in the future. But what's interesting is the actuaries at Deloitte and McKinsey and other big consulting groups around the world have spent time looking at this problem and thinking about how the shift of economic burden is going to change as we start to think less about sick care and more about spending money on wellness care. And what I really want to focus on is that shift right there, that drop from around 12 trillion to 8 trillion. How do we actually reduce and realize that gain? It's not simply on the healthcare system, it's on a lot of these technologies that we're going to develop. And one of the things that I'm going to propose to you all today is that we can use data to help get us there. We can use data-driven technologies, data-driven decision-making to help get us where we want to go, to help realize and shift that $4 trillion upstream. It's still going to be spent. It's not just going to vanish, but it's going to be shifted upstream to focus on a lot of the wellness and longevity care technologies that you've been hearing about for the last couple days. So when I talk about data, it kind of builds on the traditional wellness model that I think we're all generally familiar with. We don't necessarily do these things, but we know that if we eat right, sleep, exercise, try to reduce stress, we're going to be healthy. Really what I'm thinking about is all of the extra data that we can layer on top. You've heard a lot of great talks the last few days about various kinds of research technologies, whether it's genetic data or all of these other kinds of measurements, and I'm going to talk about some of those today. But we're talking about, yes, using the genome, using digital measurements from wearables like what I've got on, and then all of these other, what I'll call phenome-based personalizations, but this is really just measuring other characteristics about you. If you go to the doctor and you have your glucose level measured or your HbA1c, that's part of your phenome. It's an observable characteristic that is very dynamic, it changes over time, and we can measure it. And so the vision then is, how could all of this data, how could having data actually help change how we think about caring for our health? Now, in the current model today, conventional medicine, it looks something like this. So you can imagine this abstract graph here is all of the maybe different things that we can measure in the human system. And we have some onset of disease, denoted here by these green bubbles down below, and over time, that disease progresses until eventually one of those markers that we actually measure as part of routine clinical care is perturbed to the point where it would present as a symptom and get recognized as the development of disease in clinical care. So for example, maybe that top right bubble is your HbA1c. There could be perturbations that happen long before that, over years, maybe it's weeks, maybe it's months, maybe it's years, that eventually will lead to that clinical sign getting perturbed. And one of the ideas we have is, well, if we measure more, then we're going to detect these changes much earlier. We could introduce some sort of targeted therapy and provide an alternate path. And that alternate path maybe prevents the development of disease altogether, maybe it ameliorates the impact of that disease, and maybe even returns you to a state of wellness. And we call that optimization of your health trajectory, personalized population health. Now, when we start thinking about, okay, so measuring all of this stuff, what am I actually talking about? So first I want to talk about health dimensions. Now, as Brian mentioned in my intro, I'm a systems biologist. That means that I don't just study one individual protein. I think about all of the proteins in the entire system and how can we model them all. They're all interconnected. And so we need to think about the human body in the same way. If I go to the doctor and I present with some sort of heart issue, I'm going to get sent to a cardiologist, and the cardiologist may prescribe a particular medication, maybe a statin, that's going to improve my heart health. But my cardiologist isn't necessarily thinking about the rest of my health, all of these other health dimensions. How does that impact my kidney health, for example? Perhaps he's improving my heart health but decreasing my kidney health. And you could imagine the same for other examples. Maybe I'm prescribed an antidepressant and my doctor tells me, oh, this will help your mental health, but she's not necessarily trying to optimize all parts of my health. She's just trying to focus in on that one thing. And so my point is, we really need to think about all of the different health dimensions and not just thinking about these systems in isolation. So how do we do that? Well, one way that we think about doing this in more of a research setting is to collect as much data as we can that profiles all of these different health dimensions. And so on this wheel here, this is basically the extent of what we can measure. And again, thinking more with potentially research-grade technologies, not only clinical-grade technologies. We can measure the state of our genome. We can look at social determinants of health. Dr. John Newman talked about that the other day. We can incorporate data from electronic health records and the medical record for an individual if it's available. Certainly, we can use self-tracking from wearables like Oura Ring, Whoop bands, Ring Kong that's outside. We can assess the state of the microbiome. It's important to think about cognitive health. And then there's all of the information and data that we get from blood. Once we take all of those measurements and we take them over time so that we're not just looking at snapshots of biology, and I'll talk about why that's so important later today, actually. When we start thinking about the body as a system of systems, we can think about just how much information we can get from the blood. The blood interacts with all of the other organs in the body, and that's why the clinical labs that we use are so informative, but there's a lot of room for potential there to find new biomarkers and other biomarkers that might be indicative of different diseases that could be used for diagnosis purposes, et cetera. And so all of these things are being released into the blood. On the research, a lot of what my lab does is figure out ways to digitize and integrate these measurements together. We don't want to just study these individual signals in isolation. We want to look at all of them together. And then we can use new and developing technologies in data science and AI and analytics to integrate all of these data together and really learn from the data. Now, I'm talking a lot about data, and I think it's a really important question to ask because there's all kinds of noise out there about AI and all of this. Is more data always better? We need a lot of data to train whatever kind of AI model I'm talking about, whether I'm talking about a language model like ChatGPT, or I'm talking about some of the other kinds of AI that we use in research. Is more data always better? I want to use a very practical example here to set the stage for why I don't think more data is always better. So this plot right here is representing the world's genome sequences as of a few years ago. That distribution of genome sequences that we have on humans is not at all representative of the human population. And this is really crucial because we need to make sure that if we're going to try to develop therapeutics, we have data that is representative of everyone so that we're not just developing therapeutics that are only effective on some subset of the population. So why is this important? Well, a specific example is the ApoE E4 variant is a known genetic risk factor for Alzheimer's disease. But what you may not know is that its clinical impact varies significantly across different populations. And if we fail to consider this fact, which is driven by having data, again, that is representative of the population, we may not be developing effective therapeutics for the whole population, but only for certain subsets. So on this plot on the right over here, the y-axis going up and down, this is Alzheimer's disease risk. And then as I animate in, we'll see that for Hispanic and Latin descent, having this particular variant conveys very little added risk for the development of Alzheimer's disease. For individuals of Black African descent, there's extra risk, but it's still not a huge risk. The risk grows for white Caucasian, and it's very, very high for those of Japanese descent. So I just want to animate back in the distribution of human genome sequences that have been collected to date to emphasize that if this plot doesn't if it's not representative of all people moving forward, then not only is it going to challenge the development of effective therapeutics, but it's also going to challenge the development of these AI models that are going to help us, whether it's predictive modeling for some of these things, whether it's trying to determine and derive new insights and new genetic markers, new biomarkers. This is really important as we start to think about the value of data and the utility of data. So everything I've talked about, I realize might sound a little bit like science fiction. So let me kind of frame how will this maybe look tomorrow. Well, right now, when we go in, at least in the United States, when I go in for my annual physical and I get a clinical blood test along with that, it measures on the order of dozens of markers. Maybe it's a CBC, a CMP, maybe a lipid panel. What I'm talking about is in tomorrow, in this world where we have this very comprehensive snapshot that takes all kinds of data, we're going to be looking at a much more complete profiling of my metabolic state through measuring blood proteins and metabolites, way more lipids, on the order of 100 times more lipids. We can use digital health technologies to help bridge the gap between these very episodic interactions that I might have with the healthcare system. We can layer in information potentially from microbiome sequences. I know that Dr. Kabeline talked yesterday about the clinical utility of those, and he's absolutely right. That's coming in the future. And even taking information in about the whole genome sequence. There are certain genetic mutations that are clinically validated and approved by the FDA in the United States that manipulate drug efficacy, for example. If I have a particular genetic mutation, I should or should not be prescribed certain medications for certain indications because we know that I'm going to maybe poorly metabolize that drug and it's not going to have the desired effect. And so I want to say, to the comment that I just made a minute ago about this being science fiction, we have actually applied this in humans and come up with some really interesting, albeit anecdotal evidence. So the population that we worked with through a commercial wellness program that no longer exists, but it was in operation for about 5 years, from 2014 to 2019, enrolled on the order of 5,000 people. Mostly on the west coast of the United States and scattered a little bit around. And all of the data that I talked about over the last several minutes, we actually collected in this population of 5,000 people. We collected it every 6 months over time. People filled out extra surveys to try to provide extra insights into the electronic health record and medical background. And we had a couple interesting stories. Most of these were published in scientific papers in the literature. One of the most interesting stories was that one of the participants in this commercial program reported to her health coach that she had been diagnosed with stage 4 pancreatic cancer. In a retrospective analysis, the research team, we dove into the data and we saw that we had multiple time points where we had measured all of the kinds of things that are down here in the corner at these time points leading up to the clinical diagnosis of this woman's cancer. And what we found is that 13 months before the clinical diagnosis, her blood biochemistry looked very similar to others in an age and sex matched in part of that cohort. So in other words, out of the other 743, I think it was, women over the age of 55, her blood biochemistry looked mostly similar. But what we found as we progressed closer to that cancer diagnosis is that her blood biochemistry changed. And it changed rather dramatically, and it changed far in advance of the clinical diagnosis. Now again, this was a retrospective analysis, but it certainly makes me optimistic that this kind of thing is possible, given that we're collecting the right kind of data and that we have the right kinds of tools to analyze this. Potentially, we could have notified her care team months in advance, maybe 5 months, maybe even 11 months in advance, that certain parts of her biological networks were being dysregulated and that there's some sort of issue and it warrants further clinical testing. Another thing that you've heard talked about a lot over the last few days are some of the different metrics and integrated tools like biological aging clocks and some of these other things. And that's things that we have worked on as well. And I think those are a really important potential tool in the future to give a very easy to understand, interpretable metric that describes some of what I'm talking about. Because it's, even for me, it's hard for me to get up here and give a 10-minute description of some of the scientific results that we have. That's not necessarily clinically actionable. We need metrics that we can look at over time, key performance indicators, and be able to track these KPIs so that we know when to intervene, and if we have intervened, did it actually make a difference? So I think the science fiction part of what I am talking about is, as you might have guessed, the cost. Everything I've been talking about is very research grade. And the comprehensive biosampling that I went through and showed in that picture with the puzzle pieces on that wheel is very expensive. The whole genome sequence, which thankfully you only have to do once, is about $1,500 US. I think that's on the order of like 65,000 Mauritian. 54 blood proteins, 100 blood proteins, 1,200 blood metabolites, starting to sound like one of those little MasterCard commercials. All of these things, they really add up. And then the question is, well, how often should we actually be measuring these? Do we do it annually? Do we do it twice a year? Monthly? Weekly? Daily? You get the idea. It really adds up. And the bottom line is we don't actually know when we should be measuring all of these things. We also don't know which of all of these things we should be measuring. That's part of the research studies that I lead, is answering those questions. It's surely not all of these things are actually useful, and so we can trim down the list to only be measuring the things that are actually conveying most useful information. But then it's the question of when we should be measuring them. There are certain things like clinical labs that we know are generally stable. You don't need to be measuring my HbA1c every day. It's stable on a period of maybe 3 to 6 months. And I'll talk a lot about that this afternoon in my session. And so I want to close by looking ahead a little bit into, so how do we turn this idea from science fiction to reality? A lot of what we think about is next generation analytical tools. I talked a little bit about AI, where we can build this engine and it can integrate all of the different kinds of data that we collect. This might be medical imaging data, which I didn't really go through at all. It could be all of the biomolecular data, all of the biochemical assessments. It could be functional assessments, some of the things that Dr. Newman just talked about in the clinical setting. It could also be self-reports, whether that's surveys that are filled out or electronic health records or even some of the data from wearables. And then in the end, what we want to get to is deriving actionable insights, new biomarkers, new knowledge and mechanisms, new drug targets. All of these kinds of things drive progress moving forward. Once we have those data, what we like to do then is map all of them to mechanistic graphs, where all of the knowledge that I have about how a system works or how I think a system works, we can encode in one of these graphs, and then we can start to layer our data on. Now, the data might be layered on in terms of very concrete phenomenon, things like individual proteins or genes, and others are more abstract ideas that we can layer on, and then we can use AI to connect all of these together and derive new connections between these. That's really the promise of some of these new technologies moving forward, is once we convert all of these data into a machine-readable format and we can get them all in the same place, our AI can start to help us derive new insights and connections between some of these data. So what's part of the process to build it? And this is my last few slides here. What does this roadmap look like, especially for a place like Mauritius? I would say that there's probably 4 things to think about. 3 of them are here. One of them is the health system backing. We need buy-in from the payers and providers to embrace this model. We certainly need clinician participation. We need all of the doctors and physicians and nurses and everybody involved in the healthcare system to buy into this. I've heard lots of physicians over the last couple days talk about how they weren't trained specifically in a lot of these different areas in medical school. And so we need people with open minds to embrace some of these new technologies and some of these new approaches and ideas. And then the data infrastructure. Obviously, everything I just talked about is very data heavy, and even if we're not using a bunch of molecular technologies, even if we're just using something like iCope, we still need to think about how do we store the data, how do we use it, how do we derive insights from it. And I'm here to tell you that while the infrastructure is complex, it's things that we've actually already built. At the Buck Institute, the bottom 2 levels of this pyramid is done. It's implemented in clinical practice. We're using it right now in some of the active clinical trials. And this third piece is actually a separate effort that I'm involved in to build an electronic, we're calling it an electronic wellness record, not a health record, specifically targeting at collecting the kinds of data we need to help focus on longevity into the future. And some of these infrastructure will help solve a lot of the problems that come with collecting large amounts of data, the automated ingestion, processing, and then really this area up here is one of the most important. It's building user-friendly visualizations to help interpret all of these data, because if we're getting thousands of measurements per day, per hour, depending on what we're using, being able to take some of these data and then turn it into actionable recommendations, again, that's the key. So I think a lot of this is already solved. The data infrastructure is basically a solved problem. I think a lot of the clinicians that are showing up here and have been here for the last few days, I think that gives me a lot of optimism that that second piece is also well on its way to being solved. And I think toward this first one, health system backing, I think just the fact that this event is happening is a really strong step in that area. To making sure that it's top of mind and that there's buy-in from all different groups getting there. And the last piece, I mentioned there were 4, the last piece I would say is people have to be willing to participate in their own health. I spoke at the top about the kind of core tenets of being healthy, of eating right, exercise, and these are things that we don't necessarily do. I know I don't do it as much as I should. And so, that's something that we all need to work toward together, is participating in our own health. It's taking all of this, there's education that's part of that, and it's not just for the clinicians and physicians, but also just for the people who are going to be interacting with all of these tools that we're building. And with that, I will end and take any questions.
Thank you, James. That was amazing. One of the questions that came up is maybe what are the things that might be necessary to collaborate with other African countries to create kind of an educational pipeline in the region?
Yeah, I mean, I think one of the biggest things, and I'm an engineer, so I'm going to talk about data infrastructure. It really is some of the infrastructure. It's being able to build tools that are interoperable across different regions, across different health systems, different jurisdictions. I think that's really key to not just kind of the health data side of things, but also on the education platforms. It's some of the comments that were made the other day about by one of the speakers about how the church leaders in a community were some of the biggest voices and most influential voices. Yeah. Even just having the infrastructure to communicate those ideas from area to area, from group of people to group of people, is really going to help the adoption of these kinds of ideas.
Yeah, that's terrific. Looking forward, and just maybe crystal ball a little bit, what do you feel is, well, where is this going? Like, what would a doctor appointment look like, or how precise can this get, and what kind of time frame might we be in a perfect world looking at?
Sure. So as an AI guy, you might expect me to say, oh, well, I'm just going to go into a room one day and interact with an AI. Definitely not. I mean, the people are not going anywhere. The AI is simply going to be a tool that is used to make physicians more efficient, to help connect different types of expertise, bridge the gap and sorts of. So what I envision is I would love to go into a doctor and have my physician have all of my data, be able to ask me questions about, hey, how did you sleep? I'm looking at all of your sleep data from the past year, and I see that it started to go downhill. I'm looking at your workout and exercise data. Maybe I have access to all of my food and nutrition and all of this kind of stuff. And then the AI can help bridge the gap and tie all of those data into the medical care so that I actually get personalized recommendations for whatever areas I need improvement in. Because God knows we all need improvement in some of these areas, more than one probably.
Oh, fantastic. Thank you, sir. Everyone, thank you to James.